disease, or those who have mild disease but
which is on the treatment of
Okay, good afternoon, everybody. Thank you very much. The name of my talk is Taming the Demon. Well, I'm not sure if we're going to be able to do that, but let's see how far we have advanced in the last 6 months or so in terms of treating this viral infection. Right. So, if you look at the goals of COVID, what do you want to do when you treat these patients? If you have mild to moderate disease, how do you define mild to moderate disease? People without pneumonia, people without hypoxemia. If they have underlying conditions, they need to be treated at home. If you provide symptomatic treatment, if they get worse, they need to come in for hospitalization, and obviously you need to take appropriate infection control measures. And so the people whom you actually need to admit are those who have either severe disease or those who have mild disease but with the risk of getting worse with comorbidities, elderly, etc. And clearly you need to put them in a specific COVID designated unit as would have been discussed yesterday or day before. So this is the Apollo protocol which we follow for COVID-19. You can see here we classify patients into categories A, B, and C. C are severe patients going into the ICU. B patients typically need admission to the ward. You can manage them as an outpatient as well if follow-up is reliable and if they are not seriously ill, say with the help of pulse oximetry or so. And category A patients are the young people under the age of 60 who don't need admission unless they desaturate or have other markers of severity. Now, in terms of treatment for COVID, you can see here that there are more preprints and journals on this issue. And what I haven't put on here are the number of newspaper articles. And I certainly don't even want to get into social media like WhatsApp, which really is burgeoning. And it's really one of the big drawbacks we have in this disease, because we don't look at the evidence as we do for other diseases. There are too many people with too many opinions. There are very few randomized controlled trials, which are really the gold standard of treatment. And unfortunately, the Government of India guidelines are outdated. They are well behind the literature. In fact, they haven't been updated for the last 3 months or so. So the purpose of disease when you want to treat COVID is if they have mild disease, you just don't want them to get worse and you don't want them coming into the hospital. If they already have moderate disease and they're admitted to the hospital, you don't want them getting worse and you don't want them progressing to mechanical ventilation. If they are already on the ventilator or have severe disease, then your purpose is prevention of death. So if you're using a particular therapy for COVID, it needs to be able to do any of these things depending upon the category of patient you use the disease for. I'm sure many of you might have seen this slide. As you can see here, this is what happens in early stage COVID. On the left side, you largely have a viral phase where you typically need an antiviral drug. And about day 7 or so, the host inflammatory response kicks in, sometimes becomes a hyperinflammatory response and results in pneumonia. And this slide exhibits this even more simply. So whatever you do early on in COVID has to target viral replication, typically within the first 5 to 7 days or so, just like any other infectious disease. On the other hand, unlike any other infectious disease, you have a lot of inflammation when you get into the second week, typically as some immunity forms. And therefore, you need anti-inflammatory drugs here, which will ameliorate the inflammatory response. And that is why treatments have been classified into early disease, early treatments like antivirals, antibody therapy, plasma therapy, and later on treatments like steroids, which reduce inflammation. Now, there are a couple of major trials going on in terms of COVID, which really inform us as to what to do. The biggest is the UK's recovery trial, which compared the standard of care versus every one of these therapies listed on this slide. A couple of therapies have gone off the map simply because they haven't worked. I'll be talking about this in more detail, and these ongoing arms are going on. So till this data comes back, we don't know whether these drugs work as well. Dexamethasone, of course, is proven to work, as I will show you, and really is the therapy of choice now for COVID. The WHO also has a big trial called Solidarity Trial, of which Apollo Chennai and many other centers in the country are part of, comparing the arms mentioned below. And even here, a couple of arms have been taken off. The hydroxychloroquine and lopinavir-ritonavir arms have been taken off because it doesn't work. The patients have been pushed into other arms of the study, and this study is evolving as we speak to include other therapies. So in terms of antiviral agents, what do we have for COVID? Now, considering that this is a viral disease, now most of you would know that most respiratory viruses, with the exception perhaps of influenza, don't have very good treatment. Unfortunately, we refuse to learn from history, and we try to force treatments on a virus which essentially is untreatable. Not that we haven't found out how to target this virus. This incredible research has all gone on within the last 6 months. You can see here the SARS-CoV-2 docking on to the receptor. A couple of receptors here which are very important: the ACE2 receptor and the TMP-RSS2 receptor, which can be amenable to blocking with the drugs like Camostat. There is another drug called Umfenovir, which affects membrane endocytosis. This is RNA, and your common drugs like ribavirin, remdesivir, favipiravir, all of which inhibit viral RNA-dependent RNA polymerase, resulting in reduced virus production. And the drugs, including steroids, cytokine inhibitors, all act outside cell to prevent inflammation. This is pictorial as to how many of these drug activity here that we use act relatively early in the cell cycle. Some of them act relatively later. Some of them have nothing to do with the virus. They are anti-inflammatory medications. So the oldest drug we have in terms of therapy for COVID is chloroquine and hydroxychloroquine. There are theoretical reasons to consider that they might work well for COVID. Certainly some other studies, especially in vitro. So we pushed these drugs as the first therapies for COVID. One fact is very clear: please don't use chloroquine. Chloroquine causes a lot of side effects. Certainly studies on chloroquine have been stopped because of the side effects of chloroquine. Now, all of you might have seen this very seductive slide, which came out about 6 months ago, comparing the viral loads of patients who got chloroquine versus those who didn't, showing a dramatic reduction and saying that you got even better if you threw in some azithromycin into this soup. Now, it turned out that this was a highly imperfect study. There were a lot of asymptomatic patients. Some of the patients who got hydroxychloroquine actually transferred to the intensive care unit, and one died. So unfortunately, this study cleared the pitch for many people around the world, including some famous worldwide leaders who hawked the drug based upon studies like this. And in fact, the society that publishes this journal withdrew, said that this study just wasn't even good enough to meet their own standards. A better study came out from the Henry Ford Group in Detroit, USA. Again, a retrospective study. Without going into the details, hydroxychloroquine did provide a 66% hazard ratio reduction, including hydroxychloroquine plus azithromycin, suggesting that it reduced mortality. Certainly a controlled trial, better data. And you can see here how the Kaplan-Meier curves split in comparison to giving nothing versus hydroxychloroquine, and even better if you got azithromycin. Here again, you can see that days after chloroquine, you clearly had a split in the Kaplan-Meier curve, suggesting that this drug works. One thing is very clear. Hold your heart in your hand. If you're giving somebody hydroxychloroquine and azithromycin, it's like a synergistic effect on your QTc interval, and you will have to relearn your cardiology if you're giving these two drugs together. However, when people started looking at it in an objective, larger fashion, this is again a retrospective study which showed that hydroxychloroquine did not work. A publication in the New England Journal, and a publication showing that there was no association with in-hospital mortality. So the early enthusiasm for hydroxychloroquine and azithromycin seems to be fading. And this is yet another study in non-hospitalized adults. So if you're going to use a drug like hydroxychloroquine in a mild patient, mildly ill patient, then it might as well improve clinical features. You're not looking at mortality, but at least clinical features should improve. No, it did not. It did not reduce symptom severity. You can see this is a randomized retrospective study. And the best study on hydroxychloroquine was this one from Brazil, which clearly showed that if you underwent randomization to hydroxychloroquine with or without azithromycin versus nothing, you really did not benefit. And there is yet another paper just published today. I haven't put a slide in suggesting that addition of azithromycin to standard of care doesn't do anything for you. I mean, you shouldn't be surprised. Hydroxychloroquine is an anti-rheumatic drug. Chloroquine is an anti-malaria drug. Azithromycin is an antibiotic. Why would it work against a virus? So many societies, such as the American College of Physicians, say don't use chloroquine or hydroxychloroquine. Even though presidents of some famous countries may take this for their personal illness or prophylaxis, it really doesn't work, and it may even cause harm because of the known arrhythmogenic potentials. The biggest nail in the coffin of hydroxychloroquine was the recovery trial data, which clearly showed that in a big data set of 11,000 patients, no benefit in a randomized controlled trial fashion. So the hydroxychloroquine arm has been stopped in the UK because of the recovery trial data. This is yet to be published, but this is early discontinuation because of lack of efficacy. So really the pendulum is swinging against hydroxychloroquine. The US FDA, after giving emergency use authorization, has withdrawn it, right? You can't prescribe it to US patients outside of a clinical trial. Cancer patients, actually, it increases the risk of mortality. And most believe that you should not be doing using hydroxychloroquine, chloroquine, or azithromycin in this day and age, certainly in September 2020. The next drug which got pulled off the shelf to be repurposed. We are all fond of repurposing drugs. The drugs are already there being used for something else. So they tried an anti-malarial, they tried an antibiotic, and then they tried an anti-HIV drug. So they pulled lopinavir off the shelf. Luckily, the very first study on this was a fairly good study, a randomized controlled trial, which really showed no benefit, although there was some criticism in that it was given late in the course of the disease. Late in the course of the disease, most of the virus is gone. It's largely the inflammatory response, but certainly it did not work in this properly done, effective randomized controlled trial. So perhaps it might still work, but we really need more data. And so this was one drug which went off the map relatively quickly. And while this study was going out, the recovery study investigators, again doing an excellent job, and many randomized patients showed that lopinavir ritonavir also did not help, and they have discontinued this arm in the UK while the other arms continue. So yet another drug undergoes burial for COVID. Well, remdesivir is the latest kid on the block. It's not so recent now, but it still is the most popularly used antiviral. It's a broad spectrum agent which inhibits RNA-dependent RNA polymerase. It's got this cyclodextrin vehicle which has alcohol in it, so similar to IV voriconazole. So if you're going to give this to patients with renal failure, it can potentially accumulate and cause side effects. However, none of the side effects are major with this drug. Some abnormal LFTs, that's all. The first use should be always a compassionate use protocol, and this was the initial compassionate use protocol showing that about 70% of patients did better. Now, that doesn't mean much because we don't know what a control arm would have done, but relatively safe, showing relatively few side effects. One fact is obvious: you don't need to give this drug for 10 days as was originally recommended. 5 days is good enough. This trial of 5 days versus 10 days showed that 5 days is as good as 10. Effectively, that's half the duration of therapy, half the profits for the company, but good for patients. A lot. Okay, right. So I hope all you guys can see my slides once again. So this randomized trial from China looked at remdesivir in randomized fashion, and guess what? They couldn't complete the trial because there were no more COVID cases in China. So it was a trial which was futile. They really couldn't complete the trial. They really couldn't draw many conclusions from this particular trial. So you really can't call it a negative trial because they couldn't recruit enough patients. But here you can see it really didn't confer any benefit. The biggest trial we do have was this well-done ACTT trial, which is a large randomized controlled trial sponsored by the maker of the drug. And what it showed here was really quite controversial. If you were mildly ill with COVID, you required some oxygen, then it helped you. But if you were severely ill with COVID, you ended up on the ventilator, or you required HFNC, you required NIV, then it didn't help you. Kind of doesn't make real sense. It also did not reduce mortality in a significant way. The numbers between 7 and 11.9% are not statistically significant. And they had this complicated score between 1 and 8, with 8 being death and 1 being not hospitalized. Number 5, right here, requiring any oxygen, say 2, 3, 4 liters, are the only folks who benefit. 6, 7, and 8 did not. And if you didn't need oxygen, 1, 2, 3, and 4 did not benefit. So you got to use it in category 5 patients requiring a little bit of oxygen or not too much. If they get severely ill, the drug doesn't work. But based upon this data, it's been FDA approved. It is approved in India as well for treatment of COVID. Some retrospective data on COVID, again, with all the flaws of retrospective data, this particular study suggested that by day 14, there was a significantly greater chance of recovery and reduced odds of death if you use remdesivir, a retrospective study versus a non-remdesivir cohort in many of the trials done on this drug by the maker of the company. And a single center experience suggested that though it didn't reduce mortality, it's a fairly safe drug. So you can see here that the data on remdesivir isn't that great. It's okay, but it really doesn't save lives. And finally, the most recent trial on remdesivir, folks who don't need oxygen, if you just came into the hospital with high fever, but your oxygenation was good, would you benefit from remdesivir? Hardly, right? Hardly. Uncertain clinical significance. They got better a little bit quicker, but did that matter clinically? Probably not. So this is what we say in terms of remdesivir. It is on our protocol. We recommend it for moderately severe patients who require oxygen. And even if you're severely ill, we say consider it, provided you're not on a ventilator. If you're on the vent, we don't give you remdesivir, it just doesn't work. We give it for 5 days. And we suggest that you should start this drug early because it's an antiviral drug. It should work better in early disease rather than late disease, although that has yet to be proven. Clearly avoid hydroxychloroquine co-administration, reduces efficacy. There's no issue with this drug in renal failure. You can get away with a 5-day course even if your creatinine clearance is less than 10. Now, favipiravir is the desi remdesivir. You might call it that. The mechanism of action is quite the same. It's been used in influenza, and it's a Russian, Japanese, Chinese drug. Let's see how it does for COVID. Now, unfortunately, clinical data on favipiravir is scarce, and there are some non-placebo controlled trials which really did not compare it with standard of care. They compare it with other antivirals. You really can't draw a conclusion from these trials. In the early trials, however, hyperuricemia and LFT abnormalities were documented. And you can see that the Indian study is ongoing. This is yet to be published. They looked at viral loads. This is not a clinical study. They looked at viral loads in patients with mild to moderate disease, comparing favipiravir with standard of care arm. Look at the number of tablets you need to take. You might choke taking 18 tablets a day. You better wash it down with a lot of water if you're going to take this drug. And they compare it with standard of care. This is the data from the company, which is again a PCR-based study. With clinical endpoints being secondary, about 75 patients in each arm, randomized, and this is what they looked at. You could not get into the study if you were severely ill. So it's not for hospitalized patients, it's only for outpatients who don't require oxygen. And you can see here that the time for viral clearance was not significant. So this is actually a failed study, and yet it was marketed. It's been approved by the DCGI for use in COVID. There is a slight reduction in the time of defervescence by about 1 day or so, So you take 18 tablets a day for 14 days to get better 1 day earlier. So that is what it does for you, and you can see the time to clinical cure maybe 1 day earlier. If you take 18 tablets a day with a total cost of treatment of about 14 to 15,000 rupees. Abnormalities in LFTs and uric acid are there, probably not too serious, but a better study, not a company-sponsored study from India. This was the one from the US. Again, a poorly done study where they really didn't compare it with a placebo arm, showing some clearance in 62%, probably safe. But really a poorly done study. Some patients who got favipiravir, 3 patients, actually got worse, ended up getting intubated and actually died. So at least a virus should, an antiviral drug, if you treat it early, should prevent that kind of adverse complication. So this is what I think about favipiravir. Very poor studies right now. No data on reducing time to progression to ventilator. Certainly no study in severely ill patients where you need a drug, because mildly ill patients are going to get better anyway. It is expensive, and at this point I don't see a role for this drug in any patient whatsoever unless better data comes out on this drug. So we don't include favipiravir in our treatment guidelines. Now, ivermectin, you tried an antiparasitic, you tried an antiprotozoan, anti-HIV, antibiotic, and why not try an anti-helminthic drug? Give it a shot too. So in vitro, there is some data that it may be good for reducing reducing COVID, for treating COVID. However, a proper review by this organization clearly says that if you want to use it for COVID, you got to use 100 times the doses you're using right now, which nobody can use in a human. Whatever has worked in vitro is really higher than what you're able to. Or for the usual drugs, say 200 microgram once daily, are too low to affect COVID, and so it's really premature to use this drug for COVID. So what about the immune system? You've gone through a bunch of antivirals, treated everything with from antiparasitics to antibiotics for COVID. Can you use the body's immune system against COVID? And it makes sense. If you give a powerful immune active agent which knocks off COVID early in the disease, you can ameliorate disease phenomenon. You can see here that if you treat right at this stage with, say, a drug like interferon, you could potentially reduce the viral load and therefore reduce subsequent inflammation. Subsequently, the same anti-inflammatory drugs, the immune-based therapies, may actually reduce inflammation. So a useful concept that you can utilize. And the favorite drug, the old antiviral drugs like interferon 1 beta, which we have used for hepatitis C, which we have tried for other diseases, have been whipped out now against COVID. Again, a poorly done trial, because they included other things like lopinavir, ritonavir, and ribavirin in this Lancet study. And apparently, you have to give Chinese patients placebo strains. That's what the study says. And that's why it was a poorly done study. We don't know. It didn't have any clinical endpoint. So no comments at this stage. Convalescent plasma is literally now the soup of the day. What is convalescent plasma? You get COVID, you produce an antibody titer, and if there are lots of antibodies in that plasma and you push it into a COVID patient, hopefully it'll knock off all the COVID viral particles in that patient's blood. That's the way it's supposed to work. The initial trial suggested that there's a 100% recovery. These were all very seriously ill patients who got better a long time later. So convalescent plasma is very popular. People look at this as an altruistic thing. You get COVID, what do? You get better, you want to give back to society, you give plasma. It's like giving blood. So it's very altruistic and being pushed by everybody, but does it work? Well, the first randomized controlled trial of COVID took about 100 patients with plasma, and what did it say? Really, it doesn't work. Maybe some benefit in some severely ill patients, possible benefit, nothing statistically significant, and we haven't learned from history. History clearly tells us that with all these infectious diseases, if you want to use antibody therapy, you got to use it within 3 days before the body's immune system kicks in. If somebody already has antibodies, why do they need somebody else's antibody? So you got to do it early before your IgM is produced. So that early, nobody really presents to the hospital with COVID. So really, you got to give it early if you're going to do it at all. It is a safe therapy. This study in Mayo Clinic proceedings, a large number of COVID patients showed that it's just like a blood transfusion, really quite a safe therapy. The question is, does it work? This study, this is actually a preprint from the Netherlands, had to stop this particular trial of plasma therapy because they found that when they infused the plasma, the patients already had their own antibodies. Why did they need plasma from somebody else? And so the study was stopped because you already had antibodies at presentation. This is the latest study on COVID, which was taken excuse to approve this therapy in the US, touted as the latest therapy for COVID. This was a large Mayo Clinic study which took about 35,000 patients, and in a small subgroup of them, they looked at the antibody titer in the COVID in the plasma that they gave to the patient, and they found that patients with high plasma titers actually benefited when they got plasma with high titers, provided they were treated early, within 3 days of diagnosis. I have never seen a COVID patient present within 3 days of diagnosis after the 7th day. But based upon this, it's been approved for therapy. You can clearly see here there was no controlled arm, a randomized controlled trial. This is an observational study subject to a lot of bias, and the FDA analysis clearly says that if you got intubated, if you had severe COVID, for which you really need therapies, there was no difference in 7-day survival. If you went intubated and you got it early and you had a good high titer plasma, then perhaps you might benefit. So too many ifs and buts for plasma. The NIH guideline updated a couple of days ago clearly says insufficient evidence to benefit. So one arm of the US government says approved. The other arm says no, it doesn't work. Hold on. So we don't know whom to believe right now. Best is to look at the data yourself. So IDSA as well says continue to collect data, don't push it into patients, and you really need RCTs. So this is what we at Apollo do for convalescent plasma. We say if your patient comes straight from home within 3 days of diagnosis or up to 7 days from onset of symptoms, rarely have we had that particular combination among our patients. Now, people now figure out that you can have a rich man's plasma, which is monoclonal antibody, get rid of all the other antibodies in a plasma donation, purify monoclonal antibody. This is made in the lab. Again, these are all in trials, but this is where the literature is heading in terms of giving monoclonal antibody therapies for COVID. Immunomodulators, right? Now, the history of infectious disease tells us that if you modulate the immune system, now that's a double-edged sword. You are going to weaken it, but if it's hyperactive, then you may have some benefit. And you had to relearn your immunology from all the stuff that is going on with COVID. You can see here, these are where these popular drugs like that we use now, like tocilizumab, that are recommended for COVID. Steroids block off many of the entire gamut of these arms of the immune system, the innate immune system, as well as the acquired immune system. And the initial recommendations on COVID were all very conservative. WHO clearly said at that time, steroids didn't help for H1N1. They didn't help for MERS or SARS-CoV-2-1. So don't give it for COVID. What has changed? The first paper that suggested this was this retrospective analysis looking at ARDS, which suggested that if you got methylprednisolone, you might get better. Nobody paid this much attention till the Henry Ford people from Detroit, Michigan, published this retrospective trial giving methylprednisolone, fairly small doses, 0.5 to 1 mg per kg per day for COVID patients, retrospective analysis with historical controls and giving multiple other therapies. So very, very flawed trial. It's a retrospective trial, but this was the first study which suggested that there may be a mortality benefit to COVID. If you treat 8 patients, you will save 1. So methylprednisolone was widely used for about a month or so when this study first came out. Finally, the recovery data. This is the single best study in COVID so far. Dexamethasone recovery data, large numbers of patients, clearly showing that if you are on invasive ventilation, you save 1 life for every 3 treatment courses. If you are not on invasive ventilation, you save 1 life for every 5 treatment courses. So clearly showing a mortality benefit using the dose of 8 mg. That's the Indian version, 8 mg once daily for 10 days. So this is the single most important trial we have in COVID. You can see here how the Kaplan-Meier curves clearly separate whether you're receiving oxygen only or whether you're receiving invasive ventilation, it's very important to note that if you're not on oxygen, there is no difference between the two arms. And in fact, there is a suggestion that it might cause harm. And that's what the author said. If you're not on oxygen, please don't pump Dexa into a patient. Makes sense, right? You don't want to give dexamethasone to an infection unless they are severely hypoxemic. It might impair the immune clearance. A meta-analysis of all the studies published in JAMA a couple of days ago again suggests that you get benefit if you use steroids, about a 1/3 benefit in steroid-treated patients. And finally, WHO came out with this guideline 3 days ago endorsing steroids for COVID. They suggest either Dexa or 50 mg of hydrocortisone every 8 hours or so. So corticosteroids are now standard of care for COVID. Dexa has the best data. If for some reason you don't use Dexa, you could use hydrocortisone or methylprednisolone and try to use it later on in the course, if at all that's possible, rather than in the initial phase where it might increase viral replication. One issue people have raised is that you could have strongyloides reactivation if you give a lot of people steroids, and the suggestion has been made is it's better to get rid of strongyloides with a dose of ivermectin. So that is reasonable. So this is what we do at Apollo. We give all our patients who require oxygen 8 mg once a day for 10 days or till discharge. We add a single dose of ivermectin, not for its COVID effect, but to widely used for rheumatic diseases as well as cytokine storm after CAR T therapy, where IL-6 levels are in the thousands. It's quite expensive and it's reserved for severely ill patients. This is the dose, typically 400 mg once a day. Many studies on tocilizumab, but the best study is the one I've put in front of you, which suggested a mortality benefit. You can see here the Kaplan-Meier curves clearly split in patients who got tocilizumab. This is a retrospective study. But even in this study, clearly infections go up. These were all the infections the people saw. This is a very potent immunosuppressant. It leaves you without any T cell immunity for about a month or so because of the long half-life of the drug. And you can see here that in this study, you did not get glucocorticoids. So would this tocilizumab have helped had you got steroids? We don't know. So we don't know that because this study did not include steroids. People have been very aggressive with tocilizumab. They pump it in both tocilizumab and glucocorticoids right away and show benefit in retrospective studies. This group of investigators, as soon as you walked into their ICU, gave you both tocilizumab and corticosteroids, suggesting that you got a benefit. Nobody has looked at long-term outcomes. Did the patient get better initially and then died later on of a severe infection? What it did is there any benefit of adding it on later after your steroids didn't work? And the IL-6 level has become very fashionable. Really doesn't predict a response to tocilizumab because in the study there was no difference between those with high IL-6 and low IL-6 levels. Tocilizumab is a receptor blocker, so don't remeasure. It's only going to go up. And we have seen that in other cytokine storm syndromes like CAR T syndrome or regular ARDS, you have much higher IL-6 levels. So we are treating much lower IL-6 levels with a potent IL-6 blocker. Probably that's not the way to go. But probably again the nail in the coffin of tocilizumab was this preliminary release. This is not a publication yet, but this is a company-sponsored trial which says that tocilizumab did not work in a randomized controlled trial fashion. Now, when the company says that its own drug didn't work, that's pretty convincing evidence for me. We still have to await this publication. But following this publication, we have kind of cut back or reduced or minimized our dose of tocilizumab. It's really a two-edged sword. What you're gaining in terms of benefit for inflammation, you might lose with infection. And history tells us that these single cytokine interventions in sepsis, many of them really haven't worked. So I really waiting for better data before we use this. At Apollo, if your IL-6 levels are very, very high or you have severe macrophage activation syndrome with hyperferritinemia, perhaps you could use this. But in general, don't use. And if there's infection going on, definitely don't use. Other so-called IL-6 interventions like siltuximab, etc., They are there. Really very small studies. Sarilumab, good data, randomized controlled trial, sponsored by the maker of the drug, didn't work. So all these single cytokine interventions are going out of fashion. Itolizumab is Desi, or you can say Bangalore tocilizumab, made in Bangalore. Well, I don't know, and this is the only slide I have because there is no published data on this drug. This is essentially a WhatsApp drug. So I can't tell you more on that. Look at WhatsApp. Anakinra, a decent publication, a small retrospective trial, no prospective trials. This is mavrilimumab, whatever that is. It's a GM-CSF. So if you know any immune active drug, try it for COVID. You'll get a publication out of it. Whether your patients improve or not, we don't know. Baricitinib. Some of these are tough to pronounce, but this drug actually increases DVT, I'm told, and perhaps not a good idea in patients who are very thrombogenic already. So anyway, all these drugs are being tried for COVID-19, including some old drugs. They've tried all the antimicrobial drugs. They are trying some drugs for gout against COVID. Some preliminary data that it might help. Again, you need a randomized controlled trial, and this is really exotic. If nothing works, just zap the patient, give them radiation therapy. Everything will die. Perhaps the patient will too, but the COVID surely will die. So this is being tried. So far, really no proof of benefit. One thing in COVID, and I'm stepping a little out of my comfort zone here as an ID physician, is that COVID is a hypercoagulable state. DVTs, pulmonary embolisms are very common, and the D dimer may reflect COVID activity, but it may also reflect a blood clot somewhere. So we frequently measure D dimer levels in these patients. They often have not just thrombosis, but bleeding. So this is the paradox. Even though you're much more hypercoagulable, you are also much more likely to bleed. So if you're very aggressive with your anticoagulation, you might actually increase the risk of bleeding. But certainly thrombosis is a big problem with COVID. And therefore, all guidelines recommend DVT prophylaxis for all patients. And the sicker the patient, probably the higher the dose or the more aggressive your prophylaxis should be. Not therapeutic anticoagulation, but prophylaxis. This is now standard of care for COVID. This is a retrospective study showing that you might save lives if you give therapeutic anticoagulation. Most people don't believe this. Prophylactic anticoagulation in this more recent study did just as well. So nobody recommends blind therapeutic anticoagulation in COVID unless there is proven PE or DVT. You just need to prophylaxis, and this is a suggestion from the hematology group saying frequently monitor your D dimer levels, do conventional workups for DVT PE. If you can't prove it, anticoagulate them till you can prove it. So this is the standard management, and this is the CHEST guideline saying pretty much the same thing. Do aggressive prophylaxis rather than therapy. And so in Apollo, we give all patients prophylaxis, and if they are in category C, more severely ill, we give them higher doses of prophylaxis, and we look closely for DVT-P all the time. And we also suggest patients go home on at least a short course of prophylactic oral anticoagulants, although that has yet to be proven in a randomized controlled trial. So this is our management protocol for COVID. If you have category A COVID, less than 60 years, no comorbidities, we hardly do any tests these days. We send you home, we give you a lot of paracetamol and reassurance. There is no role for antiviral agents. We don't use hydroxychloroquine, we don't use favipiravir, we don't use doxycycline, azithromycin, whatever else you want to use. We do suggest pulse oximetry for category B1, the older people or those with comorbidities. And obviously, if they don't get worse, they're coming back to OP, you admit them. The moderately sick patients, we always start dexamethasone. We do recommend remdesivir because it reduces duration of hospital stay. We always start prophylactic low molecular weight heparin, and the rest of it is experimental. The severely ill patients, we start dexamethasone always. We also give higher doses of prophylactic anticoagulation, and we say you could give remdesivir if you're not on mechanical ventilation. We rarely use antibiotics routinely in COVID because the minority of these patients actually have bacterial infections. And these are the trials which you could get into. Sometimes we consider tocilizumab, convalescent plasma, but we actually have stepped down, or we don't use these therapies much in the last couple of months or so. A final word on chemoprophylaxis. This is of importance if you're a healthcare worker. Can you do something to prevent yourself getting COVID? Now, history tells us that people who are already on hydroxychloroquine, say SLE patients, they continue to get COVID. Doesn't prevent COVID if you are on it for some other reasons. However, ICMR has stood out on a limb and been the only person in the whole wide world to tell you that all healthcare workers, if you're watching this, ICMR tells you, please take hydroxychloroquine. So this, I don't know where ICMR got this data from. There are side effects, including QTC prolongation. ICMR published its own study in its own journal, peer reviewed by itself. So talk about some conflict of interest there, and said that it works. However, this study showed that you got to take it at least for 3 to 4 weeks before it starts working. Before that, it might actually increase your risk for COVID. Strange. However, ICMR continues to recommend this. Abroad guidelines don't recommend this drug. Ongoing studies have to inform us. So if you really don't want to get COVID, use personal protective equipment rather than hydroxychloroquine. Similarly, international study says don't take. Certainly, hydroxychloroquine doesn't help after an exposure. Somebody coughed in your face, no point taking 10 hydroxychloroquines after that. This is what the post-exposure prophylaxis said. It's already too late. So good data on post-exposure prophylaxis for COVID. So this is my final slide. If you've been drowsy after lunch, please wake up and get your questions ready. Dexamethasone is the only proven drug that reduces mortality. Please use it for all COVID patients who require oxygen. Prophylactic anticoagulation. This is prophylactic, not therapeutic, is a must for all patients. Remdesivir reduces length of stay in less severely ill patients, although it doesn't save lives. Plasma therapy may help if you get a patient coming in very sick, very early, almost never the case in COVID. Tocilizumab, you may, it's like saying operation successful, patient dead, right? That's one of the problems with tocilizumab. And our own desi drugs, the homemade, made in India is very much in flavor now, like favipiravir, itolizumab. They have to work. We still don't know whether they work, so more or less useless at this point, and everything else is basically theory. Well, thank you very much. I'll be happy to stick around for the next 5 minutes or so and answer any questions you might have. Thank you.
Thank you, sir, for the exhaustive presentation on treatment aspects of COVID. I think you have loaded us with a lot of information, and we can take questions from now on. There is a question, sir. How about ivermectin, doxy, zinc, triple therapy in mild COVID?
Boy, triple therapy works well for HIV, works well for TB, but not very well for COVID. Doxy doesn't work at all. Zinc, good placebo. Ivermectin, I told you, you got to give about 200 grams, 2 grams. Might help a horse, won't help a human.
I think I've answered that, sir. The next one is rivaroxaban as an anticoagulant instead of low molecular weight heparin.
Yeah, the recommendation is don't use these oral anticoagulant drugs in acute COVID while they are hospitalized. There are drug interaction issues. Reversibility may be an issue. Use them after the patient is discharged for ease of convenience.
A question from Dr. Siva is that role of pirfenidone in preventing fibrosis.
Good question. It is not an infectious disease question, but my pulmonology colleagues tell me there is absolutely no data.
Again from Dr. Siva is that is nintedanib effective?
Again, my pulmonologists tell me there is absolutely no data. There is a drug, there is a disease. Doesn't mean the drug works for the disease. You got to prove that it works.
Your opinions are on simple severe phase 3 trial. The mortality rate for patients treated with remdesivir was 7.6% at day 14, compared with 12.5% among patients not taking.
Correct. Yes, there is a difference, but it's not statistically significant. P was greater than 0.05. So it could have occurred by chance. But remdesivir is okay. It reduces symptoms. It reduces your duration of hospital stay, but doesn't save lives at this point.
Somebody has a question on role of antiplatelet for patients who have a high D dimer. Can they use aspirin?
Actually, you should be using an anticoagulant. D-dimer reflects the coagulation pathway rather than platelet pathway, my limited understanding of hematology. So please use low molecular weight heparin, not aspirin.
There is a question on interactions of remdesivir with other drugs. They're asking about inducers of cytochromes. So what is significant interactions with remdesivir is the question.
I know that you should not use it with hydroxychloroquine. There is a major drug interaction. But other than that, just look it up. If this patient is on other drugs that induce, open your book, look it up.
So there is a question on recent extended authorization for remdesivir for use in all patients, including mild patients. So what is your opinion on that?
I think that's a bit of a pharma-driven issue. If you're not hypoxemic, why do you need remdesivir? Even the study I showed you, published in JAMA, showed marginal clinical improvement. That's what the editorial there as well said. We don't use remdesivir unless you need oxygen.
So your personal experience in the recovery rate in your hospital with dexamethasone.
See, you don't know whether the patient gets better on their own or whether they get better with dexamethasone. Large trials show that many more get better with than without. So our experience with dexamethasone has generally been favorable. But you can't say that unless you do your own randomized control trial, which requires big numbers. So I would just go with the literature, and we are quite happy using Dexa in all our seriously ill patients.
The comments on duration of anticoagulation post-discharge.
Actually, there's no randomized control trial to say that. Expert opinions suggest that you should get oral anticoagulation between 2 to 4 weeks, depending upon your risk for a blood clot. If you're obese, if you have cancer, if you had recent surgery, all those conventional risk factors, plus severity of COVID, you've been on the vent for a long time, then probably a bit longer.
So because the fever in COVID is highly, it's very high and people have myalgia, can we use NSAIDs?
NSAIDs are generally not recommended for any acute illness. They increase risk of GI bleeding and renal failure. I would go with paracetamol.
Somebody has a question, do patients get better on their own or do they really benefit from any therapy?
Good question. You know, for viruses, you get better on your own. The question is, this is a deadly virus, so anything we can do to accelerate that process is being tried. But good question, many get better on their own.
So do you believe on the fact that exposure to high viral load leads to a severe disease?
There is some suggestion about that. For instance, if you're a healthcare worker and you go in without your N95 mask into a intubated rooms patient, you have millions of virus particles entering you that can potentially cause a higher inoculum. We know that for other viral infections like HIV. So probably there's a role there rather than community acquisition outside of the home setting. So where the risk is lower. Probably that's true.
Dr. Siva has a question. How is dexamethasone superior to methylprednisolone?
The biggest study has been done with dexamethasone, so I would go with the biggest study. The steroids have minor differences in their mineralocorticoid, CNS penetration, etc. So because it's the biggest study, I would go with dexamethasone for now.
There is a question. Somebody wants to know whether a single or just 2 doses of tocilizumab will increase in infection to a higher rate.
Absolutely. Tocilizumab has a long half-life, I believe about almost 10 days. So you are going to be out for 4 half-lives, which is about 30 to 40 days.
How long Dexa should be given, sir?
10 days as per recovery trial. If the patient gets better quickly and gets discharged, you stop at discharge.
Your comment on giving oral anticoagulation upfront instead of low molecular weight heparin as prophylaxis.
No, I wouldn't do that. There are drug interactions, Clexane or low molecular weight heparin, say enoxaparin, dalteparin, you can stop immediately if there's bleeding. There's an increased risk of bleeding in these patients, so don't give oral therapies and drug interactions as well.
For patients with underlying lung disease, even for category A, is there a role for Dexa or remdesivir?
Nope. Very clear that dexamethasone should not be used if you're not hypoxemic. Even WHO has reiterated this. Remdesivir, it's been FDA approved for anybody who gets hospitalized. On what basis, I don't know. Paracetamol should work as well. Once they need oxygen, certainly yes.
Dr. Sumati has a question. What about starting Clexane for a patient with COVID with comorbidities like diabetes and hypertension at home itself?
There is no data that you get blood clots if you're not severely ill with COVID. We know that about 40 to 50% are asymptomatic. We know that the majority of patients don't require hospitalization, and we don't have data that the evidence of that the incidence of DVT is higher at home. I would just encourage them to be active within their room, move their calves, etc.
Dr. Aditya has a question. Role of prophylactic use of apixaban in patients who have tested positive but are not hypoxemic.
No data, probably unnecessary. I wouldn't do it. Remember, you are giving patients drugs that can make you bleed without monitoring them. I wouldn't do this.
Persistent cough post-COVID, does it need investigation, sir?
I think a basic chest X-ray, a monitoring of pulse oximeter, pulse oximetry. You need to find out if it's just bronchitis, just leave it. If there is wheezing, treat it. If there is pneumonia, obviously that's serious. So you need to figure out what that cough is due to.
Somebody wants to know, can we change to prednisolone from dexamethasone when patient is getting discharged? Actually,
after you get discharged, there's no role for oral steroids. So you stop the Dexa at discharge. You can do oral dexamethasone in the hospital if the patient can tolerate.
Your personal experience on post-COVID fibrosis or any other system involvement, sir?
Yeah, post-COVID fibrosis is a definite entity. We don't know very much about how to prevent this, what is the prevalence, who are the risk factors. So two patients get COVID, one gets better fully, one gets fibrosis. So we don't know much about this disease yet. That really is an area which requires a lot of trials and tests.
Is there any entity called chronic COVID?
There's nothing called chronic COVID. After you get COVID, you can have a lot of post-COVID sequelae, which the next speaker will enlighten you on.
So why do patients on ventilators have high mortality?
Because you're sick from the basic disease. You've got to be pretty sick from your COVID to end up on a ventilator. That's the basic reason. Secondly, it's known that ventilatory strategies can worsen COVID. I'm not an expert on this, but but it's got to do with lung elastase, compliance, etc. So if you do the wrong kind of ventilation for a particular type of lung in COVID, you can make things worse.
So let's take a couple of last questions. Is there any difference in DEXA dose depending on the severity of the illness?
No, not so far. Recovery trial use same 8 mg. That's a matter for active investigation right now. So everybody gets 8 mg as of now.
There is a question on risk of reinfection and the duration of protective immunity.
Dr. Ghafoor will talk to you in detail last talk.
So, and the last question, role of ivermectin, I think it has already been discussed extensively by sir. So that's it. So we'll close the session, this session now. Thank you, sir. Thank you.
Thank you very much. Thank you. Bye-bye.
We welcome you again for the next session. The next session is on post-COVID sequelae. So we do not know what traces COVID is going to leave on us. So we have Dr. Vikram Das, who is a fellow in infectious disease in Department of Infectious Disease, Apollo Hospitals. So he'll be elaborating on post-COVID sequelae, opening the Pandora's box. Over to Dr. Vikram.
Good afternoon. I will be discussing on the post-COVID sequelae. So probably this is our knowledge regarding COVID-19. Less we know about the disease, probably lesser on the sequelae and the least on the treatment of sequelae. So this is very important. The timeline about COVID. Usually the mild diseases recover within 2 to 3 weeks and severe and critical diseases take 3 to 6 weeks to recover. But sometimes symptoms may persist for more than 2 to 6 weeks. And for severe disease may persist more than 6 weeks also. So this kind of patients will include as a post-COVID sequel. The terminology came with COVID like post-COVID, post-acute COVID-19, where symptoms will persist more than 3 weeks, chronic COVID-19, where it may persist more than 12 weeks. And all these symptoms are calculated from the day of onset of symptom. This is very important. So while taking history, we should always consider what is the date of onset of first symptom. The symptom may be anyone, so that date is very important regarding planning our treatment plan or regarding removal of the isolation, also with this sequelae. So the long-term sequelae are those which persist after 6 weeks. By now we all know that COVID doesn't not only affects the lung, but it affects all the systems of the body. So sequelae is going to affect all the other systems also. So this will be my scheme of presentation. I'll be discussing short cases on each of these systems, starting from vascular, cardiac, general, pulmonology, neurological, dermatological, and reproductive. So this is my first case. A 52-year-old male, hypertensive, known case of treated papillary carcinoma thyroid. He was having COVID-19 category B2. He was admitted outside hospital and treated there for 7 days with steroid and low molecular weight heparin and discharged 23 days back. Now he presented with this swelling and pain and warmth and redness in this right leg for last 3 days. He is not any other medications, only the discharge medications with vitamin B12, PPI, and amlodipine going on. Slides not more.
You can use the
So, what could be the diagnosis? Is it a right lower limb cellulitis or right lower limb lymphangitis or a DVT or an intramuscular hematoma? You can put your responses in chat box. So we did the investigations. CBC was normal. USG or right lower limb shows the venous Doppler shows the thrombosis of the external iliac veins. And the T dimer done, it was 5.3. So it was probably a case of deep vein thrombosis. As we all know by now that COVID is a prothrombotic state, and post-discharge thrombosis has been well reported there. And thrombotic risk also increased despite this anticoagulant prophylaxis. We may get breakthrough pulmonary embolism or deep vein thrombosis cases. For whom we should prophylax? Actually, the aged patients with a D dimer higher than 2 times for the normal and with a low risk of bleeding, we should give anticoagulant prophylaxis post-discharge. In patients with proven P or DVT, 3 to 6 months of prophylaxis may be needed, and in high-risk patients, 2 to 4 weeks of prophylaxis will be sufficient. Oral apixaban and rivaroxaban can be used, and we should keep in mind regarding the drug interaction, especially cortisone. Many of these patients get amiodarone, so we should be careful about these things. So this is my second case, 52-year-old male, hypertensive on losartan. He has been treated for COVID category B2 with low molecular weight heparin, remdesivir, and SCQs. He was there in hospital for a few days and then came back home and stayed for 2 weeks. There was no symptoms post-discharge, but suddenly in fine morning he was found pulseless in bed, and the family physician was called up and he declared him as dead. So what may be the cause of sudden death? Is it a intracranial hemorrhage or a MI or myocarditis associated arrhythmia or a massive pulmonary embolism, tension pneumothorax, or arrhythmia due to HCQ? The opinions may differ because many of them can be a cause, and we don't know what is the exact cause. But as per the data available, there are fatal arrhythmias reported after COVID, and this arrhythmia can be in the form of atrial fibrillation, polymorphic VT, pulseless electrical activity, and also AV block. But the interesting thing is there is no correlation with the extent of lung damage and the arrhythmia. We can get arrhythmia with a milder disease also. So this case 3, 58-year-old male, there is no comorbidity, and patient was admitted in hospital on 8th day of symptoms with SARS-CoV-2 PCR positive category C. There was a normal echo, and the patient was hospitalized for 19 days, and of which 7 days was in ICU, and he was on ventilator for 4 days. He was treated with Clexane, remdesivir, and dexamethasone. On admission, his HS trop T was 20 nanogram per liter. D dimer was 0.36. CRP was 130. Ferritin was not very high, 106. There was no pulmonary embolism on CTPA, and there was no clinical heart failure. So the patient was discharged and came back for cardiac evaluation after 3 weeks. There was no heart failure there, and ECG was also normal. Ejection fraction was 67% in echo. So the question now to the doctor was, is there anything to worry, doctor? Answer is yes, we have seen this microneedle injury in hospitalized patients, and this is not only exclusive for these patients with proven ACS or pulmonary embolism. It can happen to other patients also. And interestingly, that cardiac abnormality may be detected in the patients with normal echo. So whenever a patient complains of any heart complaints, like there is any new onset arrhythmia or any heart failure, we should always consider this post-COVID myocarditis. One study did this cardiac MR, and they did this gadolinium enhancing, and they showed this myocardial injury could be non-ischemic in 38% cases, 17% cases could be ischemic, or dual pathology can be there in around 14% of the cases. On admission, HS top T, if elevated, then the risk increases, the death risk increases, and it is a 41% in 41% in those having high top T than those with without high top T. So I'll come to my fourth case. Is an 8-year-old female. 6 weeks back, she had a history of exposure to COVID patient. Till then, she was asymptomatic. Then she presented with 8 days of fever with rash in the body and also palmar rash. And there was a new onset dyspnea for last 3 days. She had a diarrhea also. And on examination, patient had mucosal erythema. She was tachycardic. We did some investigations. She was having neutrophilic leukocytosis. Platelet was normal. CRP 199, ferritin 1022, and there was bilateral pulmonary patches. So this was the X-ray and CT that shows pulmonary opacity. So what is the diagnosis for this lady? Neutrophilic leukocytosis is acute fever with rash. Is it a staph typhus, or it's a hand, foot, mouth disease, or a infectious mononucleosis, dengue fever, or it's something new entity called the MISC, multisystem inflammatory syndrome in children. So this new entity, they can appear 1 to 6 weeks following the infection. It can overlap with the acute disease also. The criteria for diagnosis: we should have a documented fever for more than 1 day. We should have lab evidence of inflammation. More than 2 organs should be involved, and the patient must be in hospital, must need hospital admission. And there is no other probable diagnosis. As a proof of infection, COVID infection, there should be positive exposure history, or patient should have a recent history of positive RT-PCR or antibody positivity. Then only we can diagnose MISC. For treatment of an MISC, we should consider IVIG and aspirin, and we should always consider cardiac evaluation, because Kawasaki disease and this MISC can overlap, and so cardiac involvement is very common. For high risk category patients having CRP more than 130, Asian race, and those having aneurysms, they may need IVIG along with 3 days of pulse methylprednisolone. So I come to my case 5. This is a 55-year-old female, type 2 diabetic, school teacher. She was discharged 2 weeks back. She had a mild COVID-19, was treated with dexamethasone, remdesivir, and Clexane, and she had a persistent fatigue, and she was being unable to perform daily household activities. She came to doctor for this complaint only. Some investigations was done. On examination, there was no focal neurological deficit. CVC was normal, LFT normal, renal function is normal, thyroid is normal, and electrolytes also normal. So what is the diagnosis for her? Is it depression related, or she is malingering, or it's a post-COVID persistent fatigue? So the answer is post-COVID persistent fatigue. 50% of the cases has been reported as having this persistent fatigue for weeks to months after recovery, and for more than 40% of the cases has a worsened quality of life. Ward versus ICU, almost comparable incidence of persistent fatigue, but this disease is not fatal, and it is self-limiting. So we should counsel the patient. Case 6. It's a 22-year-old male student. He lives alone. He is complaining of loss of smell and taste sensation for last 2 months. He has no other complaint. He cannot recall any febrile illness in last 2 months. He changed 2 ENT physicians during this illness, and there was no ENT exam, no abnormalities. Some ENT doctor did a COVID PCR that was negative. So what should be the diagnosis? Is it an anxiety disorder or a rhinosinusitis? somatoform disorder, or it's a post-COVID persistent dysosmia. Patient was found to be positive for SARS-CoV-2 IgG. So we have seen this neurologic sequel. The dysosmia or anosmia can persist up to 7 to 8 weeks, and the dysgeusia can persist up to 32 days. One study compared the ward versus ICU. There is slightly more incidence of attention disorders, sleep disorders, memory loss, all this in the ward patients, but that is not statistically significant. We have also seen depression and anxiety as a post-COVID neurological sequel. So I come to case 7. It's a 64-year-old male, diabetic, non-smoker, no pulmonary disease, no history of ATT intake. He had COVID-19 category B2, discharged 2 weeks after 2 weeks in the hospital, and then after 2 weeks he came for OPD follow-up. He had persistent exhaustional shortness of breath, and room air saturation was 96%. This was the CT chest showing some fibrotic bands in the at lower zone. So patient asked the family physician, "Will my lung recover?" So what should be the answer? 60% mild to moderate cases, the parenchymal abnormalities may resolve within 3 weeks without any treatment. 40% cases may continue to have this more than 3 weeks and then gradually may resolve. But the elderly patients may take longer time to resolve. And this persistent hypoxemia and fibrosis there, we must consider referral to a pulmonologist. These are few CTs also. There's a bronchovascular bundle distortion that has been resolved automatically within 3 weeks. This is something called tinted sign. Here, with duration, the area of ground glass opacity has been increased, but the density has decreased. So these are sign of recovery. This is called tinted sign that came with COVID only. And this fibrous stripes that has recovered within 3 weeks. But not all fibrous bands are going to recover in 3 weeks or so. That may progress. Extensive pulmonary fibrosis can occur and patient may die also. So in such cases, we must refer the patient to pulmonologist rather than waiting for long. So these are few dermatologic sequelae, telogen effluvium, significant hair loss for women has been seen, and usually it resolves within 3 to 4 months. Few reproductive sequelae, one review has been done which indicates that there is decreased sperm concentration and motility up to 90 days. The take-home message is anticoagulant at discharge to be continued, to be considered in high-risk population. Cardiac injury can occur even with apparent normal echo, and immunological manifestation like multisystem inflammatory syndrome or Kawasaki disease can occur. And fatigue, dyspnea, dysosmia, and dysgeusia can persist for months. And mild to moderate cases of CT changes may resolve within 3 weeks or so, but it may be delayed in elderly. So this is my acknowledgement, and probably the Pandora's box is yet to open. Thank you.
Thank you, Dr. Vikram, for your crisp and clear presentation on post-COVID sequelae. There are a lot of sequelae for many of which we do not know the mechanisms, and for many of which we do not know how to treat them also and follow. So we are still learning on the post-COVID sequelae, and we think that many more is on the way for us. So we'll take some questions now. So there is a question from the audience: why in many places CT scan is used for screening instead of X-ray?
Yeah, actually, those cases where places where already the prevalence is very high and the pretest probability is very high, CT may not help much. But where there is some dilemma, and at emergency we have to try whether to put it infection control purpose only, we have to put it in a COVID ICU or to put in a normal ward. CT may help sometimes, but very early days CT can miss this COVID cases. So we have to be very careful regarding the timeline. As I said, this timeline is very important. If you are doing the CT after 5 to 6 days, then you may get some patches because the sensitivity of CT is definitely higher than that.
Correct. The sensitivity of CT is definitely higher than the X-ray. So, and there is one question from Dr. Aditya Vedula. If an elderly patient is mildly ill but has elevated D-dimer, does that call for a low molecular weight heparin administration, doctor?
Sorry, elevated?
There is an elderly patient but is mildly ill and he has an elevated D-dimer. So does it call for a low molecular weight heparin
Yes, there is
administration?
one improved VT score. If it is more than 4 or if the elderly patient more than 75 years and VT is D-dimer is more than 2 times the normal, then we should consider post-discharge anticoagulant.
Okay. And I think they're also talking about the inpatient prophylactic anticoagulation. So as you said, so we should always, yeah.
In case the patient is having mild disease, not requiring oxygen, still the anticoagulant we consider, but not oral anticoagulant. Usually in patients we consider parenteral, subcutaneous Clexane or heparin.
Okay, so is there any choice of drug for the oral anticoagulation, doctor, the post-discharge anticoagulation?
There is no clear data, but one NIH guideline shows that rivaroxaban could be used 10 milligram, and another some pulmonologists use apixaban, oral apixaban. What we're doing, we use apixaban because most of the patients have some nephrologic issue, always having some raised creatinine and all, and the apixaban is safer in that aspect. So both rivaroxaban and apixaban can be used.
There is a question, doctor. Will patients with mild disease suffer post-COVID sequelae? What is your comment on that?
Yeah, that's what I said regarding myocardial injury. We cannot predict through the lung diseases because patients with having a very mild lung involvement may later end up with a very severe myocardial disease. So actually, that doesn't matter how was that disease, but mostly the persistent features, the sequelae has two parts. Those who are having persistent features are for those who are suffering more, but those patients having really the post-COVID sequelae and the symptoms appearing later, that doesn't correlate with the earlier disease.
So use of pirfenidone in post-COVID fibrosis, Dr. Bikram.
Pirfenidone again, this pirfenidone use is based on these two trials, in police and in bullet trial, that are IPF and non-IPF patients, but that is extrapolated data. We cannot say that we can use, but some personal view or some hypothesis is there that some pulmonologists, if they can use it along with steroid in a properly chosen patient, that may delay the fibrosis and delay the decrease in the FVC. But that is a personal view only, no randomized control data.
With regards to COVID, there is no proven benefit of pirfenidone till now, actually. So discharge advice for a diabetic hypertensive obese 60 years patient post-COVID.
Yeah. So 60-year-old post-COVID diabetic hypertension, and I will also like to know the D-dimer of the patient because to classify as a more thrombotic risk and also more VT risk, because they are not. So all these to be considered. One is this thrombotic risk, another is the bleeding risk. If the bleeding risk is low, probably this patient is having having this D-dimer high, then probably is a candidate for anticoagulation.
There is repeated questions on this. Is there any guideline on follow-up CT thorax after discharge in any COVID patient? And so is there any guideline on that?
There is no guidelines, only according to the response, actually, we can choose the patients for that.
That is basically a clinical call. If your patient comes back with symptoms, it is always ideal to look at the CT to see what is going on in the pulmonary parenchyma, whether it is still ground glassing or whether it is whether the fibrosis has set in or not. So if we start seeing fibrosis, then we'll have to be wary and start doing pulmonary function test, and we have to refer to a pulmonologist and to treat the pulmonary fibrosis per se. But if it is still ground glassing, we can come to a conclusion that the COVID activity is still going on in that patient, and the question of steroids in such patients is still remains a question. We do not have an answer for that yet. Yeah, similar question. If there is a patient with persistent GGO after 6 weeks of COVID, is there any role in continuing steroids? Is this sequelae or ongoing COVID after 6 weeks?
We never know. As I said, that GGO may be the tinting that is increasing GGO with diminished intensity. That are the recovery sign that may resolve automatically. But some GGO with mild to moderate fibrosis that shows ongoing inflammation, that may be that can be that may get help from steroid. So that is again personal decisions and clinical decisions to be taken by the pulmonologist.
So what is, in your experience, how common, or as per literature, how common is pulmonary fibrosis as a sequelae of COVID?
Severe disease actually may have pulmonary fibrosis. Our experience and this as per available data, around 10 to 15% of the patient may progress to fibrosis having the severe diseases.
Is the risk of venous thromboembolism increased in discharged COVID patients, doctor?
Those patients having high risk of thrombosis, like aged patients, as I said, with a more improved VT score, they may have a increased risk of
There are few
thromboembolism.
reports of patients presenting with thrombotic episodes after discharge, but we really do not know whether they are related to COVID. And that is why the few guidelines recommend giving post-discharge anticoagulation for 2 to 6 weeks, but that is not based on any solid evidence or randomized control trials. So still we are learning a lot in this aspect. I think, is there a permanent disability or consequence of post-COVID? Is there any permanent disability post-COVID?
I don't think so.
So we do not know. Okay, so with this we'll close the session, and thank you, Dr. Bikram, for your answering the questions and your extensive talk. Thank you.
Oh my God. Importance.
So we are moving to the most exciting and the most awaited session. Yeah. So we are moving to the most excited and the most awaited session, that is COVID immunity, and where are we reaching to? What is the elusive goal of vaccination in COVID? We do not know. So we have Dr. Abdul Ghafoor, who's a senior consultant in infectious disease in the Department of Infectious Disease, Apollo Hospitals, Chennai. So it will be a live session, so there is no PowerPoint presentations here. So Dr. Ghafoor will be elaborating on COVID immunity and his lecture in this session, and after a short session of 10 to 15 minutes, it will be an interactive session, so you can start posting your questions from the beginning so that he will answer all of your questions after his talk. So let's over to Dr. Ghafoor.
Good afternoon. COVID immunity is one of the most controversial and discussed about topics in COVIDology. We have heard stories of, oh my God, the antibody is waning, antibody is falling. We have heard stories of T-cell immunity, B-cell immunity, stories on herd immunity, and Chinese whispers on vaccine. So what exactly this COVID immunity is about? How does our immune system deal with the COVID virus? Yes, the virus is entering our respiratory tract. Immediately, our innate immunity kicks in. Innate immunity means that's the immunity that we are born with. It's in our genes. It's quite broad. It's non-specific. It's not specific for any particular virus or organism. It's non-specific, broad immunity. But it kicks in within few minutes of the organism entering our body. Yes, the SARS-CoV virus is entering the respiratory tract. The innate immunity is kicking in. The first interferons come into the picture and other non-specific markers. If the virus is contained by the innate immunity, well, no symptoms, no infection, the organism is kicked out. Now, if an infection has settled in, that means the organism has escaped the innate immunity. And then we need our adaptive immunity to work against the virus. Adaptive immunity means our B cells, our T cells, antibodies, but it will take several days for the adaptive immunity to kick in. In SARS-CoV, it will take several days. The IgM start appearing earliest by 6 days, 7 days. So it will take several days for the adaptive immunity to kick in. Adaptive immunity, the IgM start appearing by 1 week to 10 days, and then the IgG start appearing by 10 days to 2 weeks. The cell-mediated immunity plays a significant role, and if the virus is controlled by the adaptive immunity, the infection is cleared. But then, yes, those B cells and T cells don't completely die off. Some of them circulate in the immune system as memory cells. They don't produce any antibodies. The memory T cells don't produce any antibodies. The T cells also, they circulate around the body, watching for the new virus entry. And if the new virus enter again, then the memory cells are activated. The memory B cells produce antibodies, and the helper T cells help the B cells to produce antibodies. That's called as the memory cells. So we have first the innate immunity, the adaptive immunity, and then the memory cells. So if all this mechanism happen, how do we get infection? How can SARS-CoV virus escape the innate immunity? SARS-CoV virus has got special ways of evading the innate immunity. They've got molecular mechanisms of evading the innate immunity. And then we have the adaptive immunity. Yes, the IgM kicks in by 1 week and then increases, reaches a peak by 2nd week, 3rd week, and then wanes off and disappears by probably 6 weeks to 9 weeks. The IgG started appearing by 10 days to 2 weeks, reach a peak, then is expected to remain at high titer for long period. But this is a problem happen. Many of the studies is IgM disappears, but even the IgG is disappearing by 6 weeks to 2 months. How is that happening? Antibody drastically dropping in level. In some of the individuals, no detectable antibody at all by 2 months. And that's how the many publications of the waning antibody titer came into the picture. And the newspapers around the world publish reports on this. Oh my God, antibody is falling. But then what happened? Over time, we had more and more publications. One publication from Austria, from Iceland. After 4 months, stable immunity in majority of the convalescent individuals. Another paper from China, the longest follow-up period of 6 months. Majority of the individual had robust, sustained antibody response at 6 months. These are the convalescent individuals. That study shows that majority of the individual had both neutralizing and non-neutralizing antibodies, more than 70%, even after 6 months. Sustained and durable, robust immune response in majority of the convalescent individual, even after 6 months. Now over next few months, we will get studies with immunity durable even after probably 9 months or 1 year. We have to wait and see for that. So what are the different types of antibodies and why? Then why the initial papers wrote stories about waning antibodies? Now if you look at the immunity response, the antibody response, you will see that once adaptive immunity sets in, yes, the IgM and IgG titer increases. These antibodies are produced by plasma blast. Once the antibodies control the infection, the plasma blasts die off. Their lifespan is 2 weeks. After 2 weeks, the plasma blasts die. So automatically, the antibody response has to come down. The IgG has got at half of around 3 weeks. So after a few weeks, the IgG has to come down because there is these plasma blasts has no other function. They have controlled the infection. So naturally, there's a peak and then there's a drop. But then we are expected to have a sustained basal antibody response. So who produced these antibodies? Plasma blasts have dead. Now there are plasma cells migrated to the bone marrow. These are called as long-lasting plasma cells migrated to the bone marrow. These long-lasting plasma cells migrated to the bone marrow produce the basal antibody, which can remain high for months or years based on the infection. In MERS-CoV and SARS-CoV-1, the antibody remains high for 2, 3, 4 years. We don't know the response going to be in SARS-CoV-2. So, the initial plasma blast and then the long-acting plasma cells residing in the bone marrow. Now, these long-lasting plasma cells are different from memory cells. Memory cells don't produce antibodies. They act only when the second infection kicks in. So that's called as the memory cells. And then why the initial contraction? The antibody was falling. But then by 6 months, it has picked up. The reason is in many of the individuals with mild symptoms or asymptomatic individual, the antibody titer takes time. They're slow to respond. So there is an initial contraction, very low titer, and then the antibody level picks up and then increases. This happens in majority of the mild infections. Yes, even then, there are a lot of asymptomatic individuals with no antibody response. 30 to 40% of the asymptomatic individuals in many studies have undetectable antibodies. It's true, but majority of the convalescent individuals has got sustained and robust immune response, prolonged immune response. And what are the different types of antibodies? How do we measure these antibodies? Let's look at the structure of the virus. We have the viral spike. Virus spike has got two main domains. One is the receptor binding protein. Receptor binding protein is very important because it is the RBD that is binding with the ACE receptor of the human cell. So that receptor binding protein is very important from immunology point of view. Now around the receptor binding protein, there is the around the receptor binding protein, there is a trimeric spike protein. So the spike has predominantly two antigens, the receptor binding protein and the trimeric protein. Then of course the virus has got envelope antigen, the membrane antigen and the nucleocapsid antigen. Most of the antibodies are produced by the spike protein and the nucleocapsid. So that's what we usually measure, the anti-spike antibodies and the anti-nucleocapsid antibodies. Now, just because there is an antibody doesn't mean the virus is neutralized by that antibody. Not all antibodies neutralize the virus. So we measure the antibody titer by ELISA methodology and we'll get a titer. Then we have to do a neutralization assay, which needs a viral culture first, and the neutralization assay is done only by reference laboratories and research laboratories. And then we calculate the titer of neutralizing antibody. So usually there is a correlation between total antibody titer and neutralizing titer. Not always, but usually there's a good correlation between the neutralizing titer and the total antibody titer. So there are different types of diagnostic kit for antibody measurement. We have got the lateral flow pregnancy kit like kits, which is used for serosurveillance studies, but these tests have got high false negativity and false positivity. Then we have got the ELISA and the CLIAS done in laboratories. Sensitivity, specificity varies. As per a recent meta-analysis, the sensitivity of most these methodologies are ELISA and CLIA 85% with specificity of 90%. If the specificity is very low, if you do serological surveillance in low prevalence population, you will get high false positivity. At the same time, if you are doing serosurveillance with a population with expected high prevalence, you should have a test with high sensitivity. So overall, you need tests with high sensitivity and high specificity. Now, if you look at, there are different methodologies give us different results. Overall, if you use a technology where the antigen is on the spike protein, the pickup with antibody rate is better if the antigen is in the spike protein. Out of the 25 licensed kits in US, 6 are targeting nucleocapsid antigen. If your antigen is nucleocapsid, your pickup rate of antibody will be lower. So there are a lot of methodological problems with antibody testing. False positivity, the cross-reacting antibodies with other respiratory coronavirus. As you know, there are 4 respiratory coronavirus, the common cold coronavirus. You can have cross-reacting antibodies. Then there are false positive auto antibodies. So antibody tests are complicated by false positivity, false negativity, variation in kids, variation in methodologies, the lateral flow device, the ELISA, clear is pretty complex, it's pretty complicated, and it's confusing. That's why WHO hasn't yet recommended antibody testing as a methodology for issuing the so-called immunity passport. We'll discuss later. Then, as per the IDSA, you can use antibody test for detection of acute infection. Yes, you have a patient more than 14 days after the onset of infection, but PCR is negative. You suspect, you can do antibody testing. But when you do antibody testing, you do IgG or IgG plus IgM. Never do IgM alone. And never do these combos. IgM one strip, IgG one strip. Don't do that. You can do the total antibody which detects IgM and IgG, but not combo which detect either IgM or IgG. And then if you do antibody testing for diagnosis of infection, do it after 2 weeks. 3rd week is the perfect time for doing antibody testing for diagnosis of acute infection if you miss the early period by PCR. An antibody test is recommended for serosurveillance. Antibody test is recommended for diagnosis of the MIS-C in children, the multisystem inflammatory syndrome in children, where we do, if you do PCR alone, you'll get only 50% positivity. If you do IgG alone, also, you'll get 80% positivity. So that's the other indication. Never do IgA alone for serosurveillance or diagnosis of infection. It's not useful. But now yesterday I read an editorial in British Medical Journal where the editorial is about the sensitivity of antibody test. As per the editorialist, if you add IgA to the IgG, so you do IgG and IgA, the pickup rate is much better. And they have got many studies from Austria, from UK, where you add IgA, the sensitivity and the pickup rate is much better. But it was questioned by many other experts. Overall, what we understand is you add IgA, you can have to the IgG, you can have a better pickup rate while doing serosurveillance studies. Similarly, papers have recommended testing IgG and IgA in the saliva. It's at least as good as the serum testing, but could be even better because IgA represents the mucosal immunity. One study from UK in healthcare workers, when they did the antibody testing, it was 0. The same IgG, IgA in serum, 0. Saliva, 15%. So there are studies with varying different findings about the role of IgA. And then what about the cell-mediated immunity? Now, there are multiple publications on the role of cell-mediated immunity in convalescent individual. There is one paper from America. They measured the T-cell response, the CD4 response, and the CD8 response in convalescent individual. You know what they found? 100% of the convalescent individuals had robust T-cell response, 100% response to CD4, and 70% response to CD8 cells. But these are in convalescent individual. Now, there is another paper, a landmark paper from Swedish student from the Karolinska Institute. They looked at the T-cell response in asymptomatic and mild symptomatic COVID patients. You know what they found? Again, in convalescent individual, 100% of the patients had robust T-cell response. And mild symptoms, 87% of the mild patients with the mild symptom had robust T-cell response. Remember, many of these patients had no detectable antibody, but they had robust T-cell response. Even exposed family members had 67% response to the T-cell. So very good, robust, sustained T-cell response. That's a very good news, not only for the natural infection, very good news for the vaccine production. We are hearing stories about reinfection. So far, 26 million people are infected with COVID around the world. 19 million recovered. There are only a handful cases of confirmed reinfection in the global literature. Yes, we heard a lot of stories about reinfection. Yeah, Mumbai 2 doctors, Chennai 2 patients, Kerala patients. There are no reinfections. There could be technical problems. First, yes, COVID positive. Then you may have a negative test. It could be a false negative. After 1 month, the patient is developing fever again. You are doing a nasopharyngeal swab again, positive. It could be false positive. You will have residual viral particles and false positive. As per the US CDC, within 3 months, don't test for the repeat COVID testing unless you're ruling out all the other possibilities and you still think COVID, you test for COVID again within 3 months. So US CDC is discouraging you from testing for COVID again. They did not say no, but they're discouraging from testing for COVID within the 3 months because reinfection is very, very unlikely within the first 3 months. That doesn't mean reinfection will occur after 3 months. No, you don't suspect reinfection usually within 3 months, but start suspecting after 3 months. I'm talking about 7 months into the pandemic, handful cases of confirmed reinfection. Why is that? Look at the MERS, the Middle East coronavirus. No case of reinfection. There was an initial big outbreak and then clusters. No case of reinfection. SARS-CoV-1, 2004, China. Only one outbreak, no outbreak again, but again, no reinfections happened after the even during 2004 SARS-CoV outbreak. So SARS-CoV and MERS-CoV has good immunity. We don't know what the immunity is going to be in SARS-CoV-2. So far, we have evidence of sustained and robust antibody and cell-mediated immunity in SARS-CoV. So reinfection is less likely so far, but we have to wait and watch. But the acid test of immunity is reinfection on the ground, and we have observed only very few reinfection. Now, even if you have get 10,000 cases of reinfection today, still that doesn't question the immunity because we are talking about 20 million recovered cases. Even if there are 10,000 cases of reinfection, even then the immunity is more than 99%. So far, reinfection is not a significant risk. Then the stories about herd immunity. We know what herd immunity is. Herd immunity is the percentage of the individuals in a community who are immune, and that immunity giving a passive and indirect protection to the non-immune people. And we don't really know what is the herd immunity cutoff point for SARS-CoV-2. Look at the measles. You have to vaccinate more than 90% of the people to achieve herd immunity because the R naught of measles is so high, where the R naught of SARS-CoV-2 is low. So you may expect a herd immunity cutoff point of 43 to 66% based on the opinion by various experts. We don't know yet what exactly is the herd immunity that we require. Now, how can we achieve herd immunity? Herd immunity is a term basically used for vaccine-induced herd immunity. But of course, you can extrapolate the definition to natural infection-induced herd immunity. But herd immunity by itself is not a strategy. It's a dangerous strategy because by the time you achieve herd immunity, a lot of people will die. And then we are hearing stories about the long COVID in recovered individuals. But whatever you do, even in Sweden, Sweden did not follow the herd immunity strategy. Herd immunity was a byproduct. They followed a no lockdown strategy and expecting herd immunity as a byproduct. So herd immunity by itself is not a strategy. Even if you do it, it's a control way of a byproduct. But that's a dangerous strategy. The real way of achieving herd immunity is by vaccination. But can we achieve herd immunity with vaccination? COVID vaccine. There are more than 135 vaccines under development, more than 35 vaccines undergoing clinical trials, 8 vaccines in phase 3, the Covaxin, the Chadox 1, the Covishield by the Oxford University. The phase 3 is happening in many parts of the world. Then There is a Moderna vaccine from States, the mRNA vaccine. Then there is a Pfizer's vaccine, the Indian vaccines in phase 2. There are multiple vaccines in trial. But the problem with COVID vaccine, we don't yet know, the efficacy that's going to be on the ground. We need phase 3 to be completed to know the on the ground, the realistic ground level immunity of these vaccines. If you look at the WHO and US FDA cutoff point, they expect a vaccine to have minimum 50% efficacy for a vaccine to be licensed. 50%. Don't you think that's a low threshold for licensing a vaccine? But that's the problem we're expecting with COVID vaccines. We don't yet know what the efficacy is going to be on the ground. But even if we get a 50% efficacious vaccine, still that's very useful. At least that will reduce 50% of the infections. At least it will reduce the complication after infection. The role of a vaccine is not preventing infection alone, it's reducing the complications. That's the role of vaccines. So overall, we don't yet know the clear immunology of the COVID SARS-CoV-2. It's highly elusive. The time will prove the real immunology of COVID virus. Thank you.
Thank you, sir, for your elaborate talk on COVID immunity, the elusive goal. So we'll take questions from now. So what are the cytokines other than IL-6 that gets elevated, and is there any role to target them in COVID?
There are plenty of inflammatory markers that are elevated. If you start measuring, you'll get a list of dozens of inflammatory markers. But IL-6 is the one that we measure because that's one of the commonly used and important inflammatory markers. And I'm sure Dr. Ram Gopal gave a good talk on the role of tocilizumab. So you know the answer already.
It is actually cytokine storm. So it is a storm of cytokines. There are plenty of cytokines which are increased, sir said. Does immunological system play a role in thrombogenesis in COVID?
Does immunogenicity play?
Does the immunology in COVID?
Of course, yes. Everything in COVID has got an origin in immunology. The end product may be, end pathway may be different, but it's originating in the immunology.
So what is the comment on the complement system in COVID? Somebody wants to know what complement system has a role in COVID, both in pathogenesis and treatment aspect.
Yeah, because in pathogenesis, complement has a role. If you look at I recently read the findings of an artificial intelligence modeling that's been circulated in the WhatsApp University of the role of bradykinin. Rather than the cytokine storm, the bradykinin storm. And they have discussed a lot about the role of complements and possible methodologies of targeting the complements.
So what is your comment on immunity passports and immunity certificates?
Few months ago, several countries requested WHO to issue immunity passport based on antibody testing. At that time, WHO deferred the decision for so many reasons I explained. The false positivity, false negativity, and we don't know how long the antibody is going to last. But then I agree. And then the immunity passport, I don't use the word passport, that's an erroneous term. I call it as certificate. It has a role because the lockdown has made huge economic impact. The negative GDP growth of our country in the Q2, the second growth quarter, was minus 23.5. And that's one of the worst in the world. So many countries are significantly hit by the COVID lockdown, not by the COVID virus, by the COVID lockdown. So to reboot the economy, the step-by-step rebooting of the economy, we can utilize COVID recovered individuals. They are immune to a significant period of time. They can travel around. They can work in containment zones. So if you don't want to give a certificate based on antibody because of the problems, we have plenty of PCR positive individuals with the names in the government system. We can issue them certificates and make them as warriors, as the frontline workers in the healthcare system, in the police, in the corporations, in the administration, and other services. We can use them. I'm a strong advocate of the not on the antibody based certificate, but at least the PCR based system.
So your comment on if a vaccine comes to the ground, So who can have that vaccine? If already many people have got the infection, so who will be eligible to get that vaccine?
By the end of this month or early next month, we will have the initial data of the Oxford University Covishield. And by the end of next month, by end of November, we will have the data from Moderna's and other vaccine trials. Now, even then, will we get a vaccine end of this year? I don't think so. We need at least 4 months after the phase 3. We may need 3 to 4 months for other procedures to complete. And then, yes, Serum Institute of India is already manufacturing vaccine. So by the time phase 3 is finished, the vaccines could be ready, but you need several months to market that vaccine. And once you get the vaccine, only 50% of the work is done. We have 7 billion people in the world, 1.3 billion people in India. How long it will take to vaccinate 7 billion global population, 1.3 billion Indian population? We have got rich, we have got poor, we need an equitable distribution. And then we have got a powerful lobby of anti-vaxxers. In America alone, 35% of the individuals voted. Even if you give us a vaccine free, we won't take it. So we have a powerful lobby of anti-vaxxers, especially in the West. They are going to refuse the vaccine. So how will you achieve herd immunity if 35% is refusing the vaccine? And then the equitable distribution. One option is you give it to healthcare workers, elderly, immunocompromised, and other risk factor group first, and then give the vaccine to other groups.
So Dr. Vidyaraj has a question. Is antibody response, is it viral strain specific?
Is the antibody response? It's a very good but complicated question. See, when the virus originated in China, it was the L strain. And then now we have the G strain. And we have the A2A. Now, the classification has changed. Now there are 5 strains. The 2019, that's called 19AB. The 19AB had L614. Sorry, the D614. It's called the D614. All the L strains belonging to 2019 had the D614. Look at the 2020 strains. The 2020, there are 3 strains, A, B, C. All of them are G lineages. That means it's D614G. There's a mutation. This D614G is the commonest strain in the world. Whether it's A, B, or C, 97% of the strains in the world now is a G strain with D614G mutation. But if you look at the vaccine development, all the vaccines in development are worked on the D614 strain, not on the G strain that is prevalent in the world. That's a matter of concern. Will the D614 work vaccine against D614 work against D614G strain? No, that's a very interesting study. Probably yes, and probably better. There's a recent study where people looked at the neutralization antibody response to the G strain. What they found was it's easy to neutralize the G strain than the old D strain. So probably the vaccines can work better on the G strains. And you know that the G strain are highly transmissible, but less virulent and easy to neutralize them. So maybe it will work. And then, you know, there are so many vaccines, and these vaccines are targeted at different antigens. And even otherwise, this D614G mutation, it is not in the receptor binding protein, it's on the trimeric protein. So it may not make any significant impact. But we don't know the future. Significant mutations can come up, and we may have to change the vaccine preparations in future. We have to wait and see.
So Dr. Somasundaram has a question. Kindly explain neutralizing antibodies and non-neutralizing. Are they both the same as IgM and IgG? Is what he's asked.
They are not different. They are not different antibodies. For example, let's take the total antibody. Let's take IgG, which predominantly IgG. The IgM can also predominantly IgG. Now, we have antibodies against the spike protein, receptor binding protein, and the trimeric protein. We have got antibodies against nucleocapsid. That's usually most of the assays are measuring these two. Now, not all these antibodies can neutralize the virus. The antibody is the same, but the neutralization capacity is different for various antibodies. So, even if you do a total antibody titer by ELISA, you have to do a neutralization assay to know the real virus inactivation capacity of that antibody. But there is one recent study. even if the neutralization titer is low, still they have potent neutralization activity on the virus.
There is an interesting question from the audience. Is there a way to measure T-cell dependent immunity in COVID? Can we measure it in a particular patient?
We can measure, but we need a research laboratory. Currently, only reference laboratories and research laboratories are doing work on T-cell immunity on COVID.
There is a question on, everybody is asking, is there a way to improve our immunity because of this pandemic? Will vitamins help? Or is it a good idea to improve our immunity because hyperimmune response is a problem in COVID? So what is your opinion on this immune boosters?
I don't know the real role of vitamin C or vitamin D. There are a lot of hypotheses that circulated in the WhatsApp and other non-specific publications. People say vitamin D helps. Maybe it may help. I don't know. Vitamin C may help. May help. I don't know. A lot of Ayurvedic and other immunoboosters, they may be working. I don't know because I don't have the expertise in those specialty to even comment on the role of these immunoboosters. There is no real published data on the scientific evidence of these immunoboosters. I'm not saying they may not work, they may be working, but we need data.
Sir, and moreover, since you are mainly working with immune compromised patients, with cancer patients and hematological patients, so what is your opinion on COVID in such set of patients? Are they doing better or are they not doing better?
Immunocompromised patients are doing worse. Very rapid deterioration in immunocompromised patients. And we have seen plenty of patients where the virus won't go away. In fact, I stopped testing. Previously, I used to repeat testing before chemotherapy. I stopped testing. I have a patient for 3 months, positive, positive, positive. There's no need of repeat testing, even immunocompromised. They are just low-level virus activity may persist. They are not infectious.
So there is repeated questions on duration of IgG which would stay in serum after COVID, and will it protect against new strains?
What is the question?
So how long will the IgG positive in a patient with COVID, and will the same IgG, will it be protective with another strain of COVID?
Okay, now I answered that question already. I discussed about it. We have data up to 6 months from the Chinese publication. I'm sure over the next few months we'll get data for 9 months or 1 year. We have to wait and see. It's a new pandemic. Overall, different strains, the antibody response may not affect significantly unless the mutation is very significant.
Okay. Why COVID deaths are high now compared to the month of April and May in Chennai? Dr. Nag Anand has this question.
I don't know. I don't know the answer. Is the death really increasing? I don't know about it. And I don't know why. We have to look into it. How can we answer that? Because we need to do a detailed analysis of the comparative mortality and various determinants. I will not give my personal opinion on that. I don't have data.
Dr. Vidyaraj has a question. Can passive immunization with antibody be used as therapy or as prophylaxis?
Antibody, that is plasma therapy. That's discussed already.
Scientists say that COVID vaccine is not the 100% remedy. What is your opinion on that?
COVID vaccine is not a 100% remedy. It's one of the most important tools in our armamentarium. But COVID vaccine will not make COVID disappear. COVID will be with us for a long time. But we need a vaccine.
Dr. Siva has a question. Will COVID infection unmask latent TB infection?
Can COVID infection unmask latent TB infection? I don't know.
If vaccine is available, whether previously infected persons can also take the vaccine?
Yes, previously infected people can take the vaccine and should take the vaccine.
Okay. So in what way will it help them? So if they already
the immunity. The immunity is not, yes, we know that's pretty durable immunity, but we know that it will not last forever. It's not going to last your lifetime. Maybe more months, maybe a year, maybe 2 years, maybe 3 years, but not lifelong because of coronavirus.
So what is your recommendation on testing? Because there are several questions on which antibody is specific, which is sensitive. So what do you recommend for the general practitioners or as a clinical, as a clinician for diagnosis of COVID? Sir?
For antibody testing.
Antibody and antigen, and your comment on antigen also.
Okay, now antigen testing is done antigen testing is a rapid testing. The new ICMR guideline released yesterday is recommending rapid antigen testing of all individuals in containment zone. Very difficult task. At the same time, in clinical practice, We prefer in symptomatic individuals, you can do an antigen test. If positive, that's positive. If negative, if you suspect again, then you do a PCR test. At the same time, you do a screening, a pre-surgical screening. You do antigen test, that's negative. You don't need a PCR test. An antigen test negativity is good. But in a clinical case, if the antigen is negative, you still have to do the PCR test.
Somebody wants to know, is the mortality really higher in healthcare workers compared to the normal population?
In WhatsApp I read that in Chennai the mortality among doctors is significantly higher than non-doctors. I don't know why. We need detailed analysis of the determinants and the the demographics of these populations to give a specific comment. But I read that.
So, a particular question was asked on day one. I think you're the right person to comment on that. The question was, when do you think is the right time to reopen schools for the
Okay,
community?
it's a difficult question, but my recommendation, if somebody asks me, my recommendation will be no, it's not yet time to reopen the schools. We reopened our economy fully last week. That's not because the virus is under control, it's because our economy is crashing. India is experiencing probably the highest number, still may increase, a rapidly increasing number of COVID cases in the country. We are forced to reopen our economy. We are forced to open our interstate, intrastate borders because our economy is crashing. Yes, we need to save lives, but we need to save the economy and livelihood. But schools, we need to wait. We need to see, we need to look at the numbers of the new cases in each and every place and make a decision based on the local epidemiology.
So, whether the virus can be transmitted by blood transfusion, whether blood transmits the virus.
Blood transmits the virus.
It is possible, but
Is it possible? If you ask me, it's not impossible for some of the virus, but it's a respiratory virus. This is not the virus that is usually circulated in the blood. You got the antibodies and cells in the blood, but not the virus. Otherwise, we could have done an antigen test or a PCR test in the blood. We don't do that because that's not how the virus works. So I don't think this is a virus that is transmitted through the blood. But let's get studies. Science can change. Who knows?
sir, update about the Russian vaccine, please.
Oh, the Sputnik. Yesterday, the Lancet published the combined phase 1 and phase 2 of the Sputnik. Excellent immunogenicity and safety. The small population of 76 individuals, but excellent immunogenicity and safety with some mild fever, body pain, headache, injection side effects. But we need a phase 3. Yes, Russia has started using it in volunteers, but we need a proper phase 3 to know the real efficacy and safety. One of the problems with a vaccine of low efficacy will be the antibody dependent enhancement. If the vaccine is of low efficacy, yeah, you will have some level of your antibody response by vaccine, and then you get a proper COVID infection. There will be enhancement and the severe infection after that. You experience that in dengue. We are familiar with antibody dependent enhancement due to the dengue vaccine. The same thing can happen if you have a COVID vaccine that is really not efficacious. We need to be careful. That's why we need a phase 3 for all the COVID vaccines.
So we'll take a couple of last questions. So somebody wants to know, where are we now? Are we in the rising slope? Are we at the peak? Have we reached the peak, or are we yet
in
to see
India?
the peak?
We are in the rising slope. Probably we may reach the peak in the next few weeks or a month. We don't know. Currently, we are in the rising stage.
And somebody wants to know, as per you, when will the pandemic end? At least when will it turn out to be an endemic or something?
Maybe a year. And I'm not a politician to answer that question. Usually that's a politician's answer. But probably I will say, if I'm a politician, I will say we have to wait for one more year or more probably, so that the virus will become endemic.
Dr. Jenny is asking about your comment on ICMR vaccine.
ICMR vaccine is actually the Bharat Biotech ICMR. Bharat Biotech's vaccine is a Covaxin. Covaxin is currently just finished the phase 1 and they are undergoing the phase 2. The phase 1 response is very good. The safety in phase 1 is good. Phase 2 will tell us the immunogenicity. Let's hope for the best for the Indian vaccine.
There are 2-3 questions on the same point. Antigen testing pre-surgical or in asymptomatic patients, and what if an antigen test is negative? So antigen test, if it is positive, it helps. If it is negative, it doesn't help. we need to do a PCR to make sure the patient is really negative.
In a symptomatic individual, if the antigen is negative, we need to do a PCR. In asymptomatic, just for screening, if antigen is negative, that's negative, don't do PCR.
Yeah, I think we will close the session with
Sure.
this. Thank you so much, sir, for your elaborate discussion on COVID immunity and vaccines in COVID. Thank you.
Thank you.
So I would like to thank every participant and all the coordinators of this program, be it marketing and the technical group.